with our vertebral challenging like we've learned in the past. Okay, you can go ahead and sit up. A couple of things that can be really important nutrient-wise that we want to think of. First, our B vitamins, especially B6, can act as a diuretic a little bit. Sometimes you'll get some inflammation and swelling that will create that numbness and tingling, so we could look at that. Any healing of the ligaments. We had already talked about phosphatase and biast, but ligaments have a very poor blood supply. One of my favorite nutrients that I'll use for MediHerb is something called gochu kola complex. Gochu kola has ginkgo, which will increase blood supply for structures that have a very poor blood supply, and then the gochu kola as well. A lot of times we'll use Ligaplex 1 or Ligaplex 2 to strengthen those ligaments so that we can hold that together a little bit better. Maybe even the carpal ligament coming across here will have some weakness that's creating that problem, so strengthening of the ligaments. And again, we can further test that from session 1, where we can go through any joint in the entire body. We'll just say that we're starting off with our wrist extensors. They're strong in the clear, and then I could create a little bit of a tractioning of her elbow or her shoulder joint. It's weak. I could traction her wrist joint. It's weak. I could traction her leg or her ankle, and that creates the weakness again. I've got a generalized global ligamentous laxity, and I really want to focus on it from that point of view. So that can sometimes help you determine what you want to do. And another thing that'll show up from that particular technique also is going to be with the adrenals. So we want to look at what's happening there. When you've got very weakened adrenals to the point where you have a lot of ligamentous laxity, then you will tend more towards having a lot of muscular tightness. You almost have these muscular bands trained to give you that same support that the ligaments were trying to do originally. Pisiform hamate. Very, very similar to what we were just doing with the carpal tunnel, except this time our weakness is going to be on the flexor digiti minimi side. I could have her again therapy localized to the different entrapment points here along the flexor digiti minimi. On this side, I could go right over the pisiform and hamate, which is a very common place that I may need to adjust. Typically, in this case, we're either going to have more of a medial to lateral adjustment on it, or a medial, in this case, anatomical position. We're going to be going from lateral to medial or medial to lateral. If we come up along our flexor carpi ulnaris side, there can be some entrapments, but very commonly right at that elbow crease, where we typically think of as our funny bone, right where that ulnar nerve comes through, it can get entrapped in some scar tissue in through there as well. So we could therapy localize over that. Again, over the corticopectoral tunnel, the scalenes, and over the neck for seeing what's going on with that pisiform and hamate scenario there. And then we move on to the elbow. We talked about that briefly. Again, making sure we check all of the muscles that we've already learned how to test in the separate video above and below it. And certainly adjusting them. We've got a couple of our different joints that are going to be here. We've got our humeral ulnar joint, which is going to be that really big solid one that sometimes you actually can feel a pretty big locking, and you actually will have a patient that's stuck a little bit more in flexion and they're not being able to extend their arm completely. Then we have our humeral radial joint between the humerus and the radius, which allows us a lot of our rotation. So if the patient's having an issue with pronation and supination, we want to check that joint. Sometimes that can get locked up. And then we've got our proximal radial ulnar joint. Okay, so where we have the radius and ulna down on that distal area, the radius and the ulna actually still have a connection there, and sometimes that will prevent some of our proper pronation and supination as well. So we want to look at all of those particular joints. Typically here with our elbow, when we're doing our muscle testing, a couple of very important ones that we're going to see is going to be with our brachioradialis. So that thumb up position again, having the patient push up, you'll see it stick right out. That a lot of times will create pain, especially when people are lifting things and it's hurting in their elbow. And we'll want to check both ways. While the patient's trying to go into pronation and I'm trying to go opposite of that, I'm going to be testing her pronator teres. If we're going the opposite direction, I'm going to be testing her supinator as she's trying to go into supination. The supinator is a very common place of entrapment with that radial nerve as well. So we can take a look and see what's going on there. Sometimes we'll get some different nerve sensations going on, numbness, tingling on the back side of the hand, and our extensors being more weak. And again, using our extensors is one of our major testing mechanisms with everything associated with that elbow there. Our extensors, especially when we have more of that tennis elbow, that backhand, where we're using that our extensors a lot more, very common to have a lot of origin insertion issues with those extensors in that particular area. Same thing holds true for almost all of the upper extremity and the lower extremity. Again, make sure that we strengthen the muscles. Many times they will have had some type of injury, so we want to look at our origin insertion type technique, look for a strain, counter strain, and look for our Travell type trigger points, all in that whole mechanism there. There may be a compaction type injury, so we want to be able to take a look at what's happened. If the patient had fallen directly onto the shoulder, we have that compaction. Remember that we'll typically have a scenario where every single muscle around that joint will test weak, typically except for one. If I were then, let's just say that strong, or one of the weak ones is the deltoid. If I were to create a little bit of a distraction when it was a compaction injury, and then I retest it, that strength will come right back. Let's just say that the bicep is the one that was weak. We tested every single other muscle. The bicep is the one that was actually strong in that scenario when all the rest were weak. What we would then do is actually repeated muscle activation by the patient, probably 20 or 30 times, then retest the muscle, and we would see the weakening there. Very likely would have to do our origin insertion technique, feel and see if there's any issues with some trigger points and fix those. Then that would end up fixing and turning on every single other muscle in the entire joint for that compaction injury, and that'll be really helpful there. Alright, so we've turned on all of our muscles. If origin insertion, strain counter strain, Travell type trigger points don't do anything for that, then we're going to want to look at our circuit breakers. Remember, all muscles have 5 circuit breakers for them, and we'll go through all of those. We'll look at our neurovascular points in the head. We'll have the patient go through the breathing patterns, see if there's any indication with cranials. So our cerebral spinal fluid, how that's pumping and flowing. We could have our therapy localizing over the neck, in this case for the nerve supply for things that are going down the arm. We could have the patient we just went over all of our alarm points, so we can check the acupuncture meridians that are going on and associated with each of those. So we've got our neurovascular points, which in this case they're most all anterior and posterior. In this case, when you're going through, you could actually just test for the anterior ones. If they're positive, you always want to treat anterior on both sides, front and back, to stimulate those, get that flushing taking place over the neurolymphatic, or sometimes called Chapman's reflexes. And then we want to support nutrition. In the case of the lung, the deltoid muscle, we might want to look at lung nutrition. Maybe they've got some kind of a cold, a bronchitis. We want to support the lung directly. Or if it was just more of an origin insertion, we'll use that phosphatase type enzyme. Maybe there's a lot of inflammation. We'll want to look at things like multizyme in between meals to help break that down. Antranex to help with any mast cells that had broken, and you're increasing the histamine in the area. Or you might want something just as simple as a fish oil to help with our essential fatty acid pathways and keeping that inflammation down as much as possible. And as any injury, any amount of rest, icing it, keep that inflammation down, compression and elevation to keep that down, ultimately is where we want to look there. Golfer's elbow, instead of our extensors with that extension, we're going to have more of a problem with our medial aspect of our elbow here. So golfers, as we get that swing through, you're going to be flexing our wrist flexors. In this case, we'll have more of a problem with that medial elbow. Everything else holds true for adjusting the elbow, with just a little bit more attention to those medial musculature, our flexor carpi radialis, things of that nature. Okay? Again, all of our origin insertion, strain, counter strain, fascia release, challenging, and add any of that nutrition that we need in that case. So we're moving up. We've gone from carpal tunnel and pisiform hamate to our lateral and medial epicondylitis, elbow issues. Now moving up to the shoulder. What's really important, a little bit different than the rest of that, is just how complex the shoulder can really be. And that being said, we want to try to follow the same pattern every single time so we don't miss what we need to. Let's say, for example, that we're looking for a problem going on in the shoulder, and just for ease of the camera, normally you wouldn't necessarily have to use this particular shoulder muscle. But we'll say that we've got a strong supraspinatus. Okay, I'm going to start at the most medial connection here over the SC joint. So I'll have our therapy localized over that SC joint and see if a strong muscle has weakening. And I would normally probably use a leg muscle in this scenario, but just for ease of the camera, that's why we're doing that. So the SC joint, a couple things to keep in mind. You don't want to be directly under the SC joint where it's coming together with the sternum, because that's going to be K27. It's also going to be neural lymphatics for our sacrospinalis muscles. So that could really be stimulating several other things that are going on. Make sure you're directly over that SC joint. The other thing that's really important to understand is this whole mass of everything, all the muscles, ligaments, and tendons, the only bony attachment that you have to your axial skeleton is directly at this very small SC joint. Still being a peripheral joint, so we're always going to want to adjust opposite of the direction that challenges. Meaning, we start with a strong muscle. If I challenged more inferior to superior on that, and it created weakening, I'm going to want to adjust superior to inferior on that SC joint. Okay? So now I'm going to be coming along, palpating along the inferior side of that clavicle, and as I'm coming along, you'll feel that depression. If you're right underneath that, you're going to feel that coracoid process. We've got our coracobrachialis that's going to be attaching there, and our pec minor. It's very, very important. So we want to look at both of those muscles. The attachment itself can sometimes be very tender. All right? Going through our different muscle tests, we want to make sure as well we could have our therapy localized just underneath that clavicle, because we don't have a specific muscle test for the subclavius. I could just therapy localize and see if that goes weak. I may have to do some spindle cell work to that subclavius, because as we know, when this patient's lifting their arm, we're going to get a rotation of the clavicle here that has to take place in order for me to be able to get that full range of motion of the arm. Okay? We also need that scapulothoracic joint to be moving. You could have a scenario where this scapula is adheres to the rib cage and not moving very freely. So we want to look at the subscapularis and the serratus anterior and how freely that subscapular, the scapula is able to be moving here. So as I'm coming up, one thing that you'll see people do sometimes is as they're coming up, naturally you will actually externally rotate the arm and it'll be a little bit freer range of motion. But when we're doing it with a patient, we want to make sure, regardless of how we're doing this, whether we help them with the external rotation or not, is that we're doing it the same every time. Sometimes you'll see people, oh look, the range of motion is right about here. They'll do a little bit of their work and then they'll create external rotation and will have way more range of motion that they would have had anyway if you created that same range of motion. So just make sure that you're being consistent with the way that you're doing that. Still coming out along laterally as we make our way out to the AC joint. Now this is a very common one to actually have an impingement here at the AC joint. It could be separated, and we'll have more of an issue with people that are holding onto their bag. Maybe they've got a school bag that they're holding onto their shoulder, creating a separation here. Or one of our orthopedic tests, and we create compression of that AC joint, can light up that particular pain that's there. So we're going to want to, again, adjust accordingly. We may need to use some kind of a kinesio tape or a brace to maybe hold that AC joint together. One of our adjustments that we'll do, let's say that it does need to be held together, I can actually hold the clavicle together with the scapula, almost like I'm pinching that, and I can keep the patient's arm nice and loose and create that rotational motion. Sometimes you can kind of feel that just click right back into place while you use a very simple, very gentle adjustment for that patient, like that. If it needs to be separated, not as common, but we can still adjust that in a high velocity adjustment or use the arthrostim as well. And we'll go through and muscle test all of our muscles associated with this particular shoulder. So we already had therapy localized to the subclavius. If they were laying down, just for ease, muscle rotated in, stabilized, got my pec major clavicular division, pec major sternal division. I could check her deltoids from this position. I could check her anterior deltoid, her posterior deltoid, and then if I have her coming straight back towards me and stabilized, that'll be her rhomboids. Okay? Now I'm working my way out. I've already done my deltoid, and I can start checking some of the other muscles here. I could check her supraspinatus from this position. Thumb up again, about 20 degrees, and holding there. I can check my serratus anterior. I can feel over the scapula, feel it for it winging, and have her push up against my pressure and see what's happening with that. And if she were standing, go ahead and stand just for a second. We want to internally rotate, hand in the back pocket, and I'm actually pulling out for her latissimus dorsi, and it's very, very important. Why don't you go ahead and sit down again. Other muscle tests that are very important. I've got my biceps and my long head of my biceps as she's pushing up into my hand in this direction, because there's a flexion component of that that can be an issue with that shoulder. I've also got the long head of the triceps, and my triceps as a group as I'm pushing this way and she's trying to extend. So I'm able to really test all of my muscles coming around. Now getting to my rotator cuff muscles. Out to the side here. If she's extending, I've got my external rotators. First off in this position is going to be infraspinatus. External rotation down to the side is teres minor. So infraspinatus here. Internal rotation, exact opposite, is my subscapularis as she's trying to internally rotate. This is very important to understand here, is that how this whole glenohumeral joint is held together and has its stability. Two of the most important muscles we need to look at is what's taking place with the supraspinatus tendon that's able to hold, and also with that subscapularis. Alright, so we're testing that subscapularis, infraspinatus, teres minor as she's trying to externally rotate, and teres major as she's trying to internally rotate. So now we've got my whole rotator cuff on top of any other orthopedic and neurological tests that you want to be doing to evaluate. Usually when you get all of those muscles turned on and firing facilitated the way that you need to be, whether again origin insertion, our Travell type trigger point, strain counter strain, you've cleared that, you've adjusted, you look through your 5 factors, those muscles are firing the way they need to. Almost always that will hold in a very strong way. If the patient does come back and it didn't hold for longer than a day or two, maybe it lasted a little longer than that, you might need to add the nutrition more specifically to get that to hold, and that's very important to understand. Okay? So we've worked our way through the shoulder here. Now, with the glenohumeral joint, why don't you go ahead and lay face up for me. The glenohumeral joint itself may need to be adjusted. Most of us think of a dislocation and your shoulder is literally going to be sitting off in left field, typically in that anterior and inferior position. If it just happens and you're out in the middle of the woods and you can get that reset very quickly, then that may be a choice that you want to make. If that sits there for any length of a period of time, when that patient, they'll be guarding their arm in this position, they'll almost be holding it up, it'll be incredibly painful. You won't be able to do this on that patient unless they'll pass out because of the kind of pain that they'll be in. Also, all that musculature is going to be so tightened and holding in that you probably won't let that be able to move at this point. But sometimes, even more of like a subluxation, we have a little bit more of a subluxation kind of anterior and inferior where it's not a full dislocation. What we'll end up wanting to do to help kind of, and this works in both scenarios, the subluxation and the complete dislocation, is we've got that arm, we're going to want to traction it a little bit more in that anterior and inferior position, take a little slack off of it, and I can take my whole hand, put it right up into the axilla, so the back of my hand is against her rib cage. So now I'm going to take that arm across almost like a lever. So when I lever that across, that's taking her glenohumeral joint, the head of her humerus, tractioning it out laterally away from the lip of the glenoid fossa. So I'll have it a little bit coming towards the ceiling at this point, around the lip of the glenoid fossa, and rotating it back down into that glenoid fossa. So we're coming forward a little bit and rotating it out and around so that it can come back in. The whole key to this is to make sure that your arm is up into that axilla and you're able to create that leveraged position, pulling that humeral head away from the front of the shoulder at that point so that you can get up, out, and away and set it back in. Another one that's important, why don't you go ahead and sit up for me. I'll do this from the back side, is the slipped bicipital tendon. What'll happen, a couple of different ways that we could see this, is just a completely weak biceps, both the long head and just as a group with the biceps here. Another thing that we'll sometimes see is maybe we'll start off with a strong muscle. Go ahead and hold nice and strong. I could have her therapy localized directly over the long head of the biceps, right through that biceps groove, and that will create weakening as well. Sometimes I even need to create a little bit of tensioning medially, because it almost always will come medially, and that will create a significant amount of weakening, especially in that bicep, but pretty much any muscle that we test. So when we've got that medially placed biceps tendon, what we're going to want to do is be able to bring that back into that bicipital groove. All right? So we will have, from medial to lateral, our tension holding it more laterally. The position for the patient is that I'm going to be bringing her into extension of the arm. I will be externally rotating the arm in this position, and it's almost going to be like a huge throw, like she's throwing a football or throwing a baseball. Okay, so she's in this extended position, externally rotated. I'm still holding it more laterally, and now as she comes up, and we go into internal rotation, and this is the key part of it. While I'm holding laterally, her whole muscle and everything is moving medially so that I can hold and bring that biceps tendon more in that lateral position. All right, we may need to get some kinesio tape or some type of way to hold it and keep it there while we're healing. And we also had the slip of ligamentous tissue that's holding over that, and we may need to give some ligamentous support. So we've got some Ligaplex, some Gochu Cola again, things of that nature. It may be very inflamed, so fish oil, some Antronex, Multizyme to help with the healing of that ultimately, and it may need to be done a few times, especially if you're not going to be holding that with any type of bracing or taping. So those are a couple of very important things there with those. Now, a calcific bursitis, any bursitis in the entire body, we want to think of as a scenario where it's locally way too alkaline. So when we have a local alkalinity, we want to bring up the acidity of the area. So we could use things like apple cider vinegar. A little bit harder to soak a shoulder into some type of a tub. You could even grab a washcloth that you soak in half water, half apple cider vinegar. The patient could orally take apple cider vinegar in a tableted form. You could use Cal Ammo, anything that's going to help acidify that tissue. Also, local alkalinity, the most alkaline toxic substance the body produces is guanidine. So we want to help the liver be able to flush guanidine as efficiently as possible. Beta-col is going to be very important to help flush that guanidine through the liver, so we could use that as well. Our essential fats to help with anti-inflammatory purposes, and even something like a anaerobic type workout where we're going to increase lactic acid to again acidify an area where a bursa has become a problem is something that we'll be able to look at there. And we've more or less covered what we need to with the shoulder. One thing to keep in mind though is with the scalenes here, we could use any muscle test. Typically one of the easiest ones that we could use is going to be our wrist extensors. If I want to, now all of these muscles are strong, the patient seems like they're doing pretty good. I want to make things a little bit more provocative. Maybe I could close down my chest cavity just a little bit, put some pressure in that corticopectoral tunnel, and or, in this case, just have her flex her scalenes, kind of creating a little bit of compression of the nerves that are going to be coming through here, and then retest my extensors. All right? That's the whole beauty of applied kinesiology, is I could have no problems in the clear, but once I start challenging the body through things we normally do, we're moving around, we're flexing, we're extending, sometimes we're hunched forward, we want to be able to do and handle those positions without again creating weaknesses, numbness, tingling, and be able to challenge the body in that way, and that's all part of what we call functional medicine. We can functionally handle those types of things, so that's going to be important. Now the TMJ, why don't you go ahead and lay face up for me. Some of this will be easiest when you actually go back and study it point by point, but I want to get the basics down so you can kind of follow the flow of what we need to do with our TMJ. So I'm going to start with just a strong muscle in the clear, and what we're going to have the patient do is therapy localized to the TMJ on both sides bilaterally. Now this is going to be more or less looking for a gross pathology within the TMJ itself. We don't really want to see this particular one be weak. So we have our therapy localized. Let's say that that's strong. If there was some type of a weakening on that, we may need to get some x-rays, some photographs, some films to see what might be going on in there, so that we can take care of any issues. They may need to see their dentist or something of that nature. Now, as we're therapy localizing again, that's strong in the clear. Now we want to start being a little bit more functional. So we'll have the patient open the jaw nice and wide. So on opening, does that create weakness? A couple of things have to take place for the body to be able to open the jaw. At first, you're going to have the muscles here, your masseter especially, your temporalis, they have to actually start to let go for the jaw to be able to start its opening position. So those might be holding on too tight. We may have a scenario where we actually have to turn down the spindle cells of those muscles. So again, pushing together those spindle cells to turn that down. We could, if that showed up on jaw opening, I'll have the patient therapy localized one side versus the other, and I could also have her therapy localized over the temporalis, over the masseter muscles. I could have her do it over the pterygoids and see which of those particular muscles we need to turn down the spindle cells. So, and then at the very end, to really get maximal opening, we need our anterior belly of the digastric muscle to be able to get that full opening of the jaw. So when that's going to happen, we want to make sure that we're checking and seeing what's going on there as well with that anterior digastric. So we went through full opening. We'll check out those particular muscles, and we'll go through the rest. Go ahead and double therapy localize for me. So we had full opening. Now we're going to want to have the patient, from an open position, close it, and we'll be checking more of our closing type muscles. And we can go through again and therapy localize the muscles individually on each side. We'll have the patient lateralize to the left and recheck, lateralize to the right. Now all the muscles are written on your charts. You can memorize all the ones involved, but you just understand the basic pattern. We'll have the patient protrude the jaw up towards the ceiling, outwards, have her retract it, and we'll even, when we close, we'll have the closing actually with a little bit of biting of the teeth, so we get really good contraction there that's taking place. Which brings up a good point, is what could happen with the neurological tooth if we have an actual tooth problem. Well, we can therapy localize for that. We could have the patient therapy localize on the upper and lower on each side. If any of those create a scenario where a strong muscle becomes weak, we can therapy localize each individual tooth, and it works exactly like a vertebral challenge. We'll challenge the tooth in its different directions, find the phase of respiration that negates it, and then we'll go ahead and it's more of a respiratory type adjustment when we're doing that for a neurological tooth. Now understand with both of these, whether it is a tooth issue or with the TMJ, 35 to 40% of our nervous system is related to that TMJ. So when we've got neurological issues, if we've got balance and proprioceptive issues, we always want to make sure we go back to and see the functioning of that TMJ. And we can see visually, is it lined up the way that it's opening and closing? Or do we get a shifting over to one side as we're opening or closing? Very important to determine the differences there with what's happening. Occasionally, especially one of the most common things that you'll see is a clicking of the jaw, and the actual meniscus is not sliding and moving the way that it's supposed to. One of the things that we'll end up doing, you would have gloves on, take your thumbs and you'd be grabbing basically over the lower portion of the teeth and grabbing the rest of the jaw with your hand. You'll basically be pulling anterior for the patient, inferior, and then coming up behind, which will open up that joint space, allow the meniscus to kind of reset itself, and then it should create a little bit more of a gliding motion when we're working with that. Okay, so once we strengthen all those muscles, reset that meniscus if it needs to, that'll go a long way. One other key component that could be important for the patient to understand is that we could do this in a supine position and not completely fix everything. We may need to go through that whole testing procedure, jaw open, closed, right, left, forward, backwards, biting down a little bit harder, go through that whole scenario while she's supine, while she's laying on both sides, sitting up and standing in each one of those positions, because certain things may show up in different positions that don't just while she's supine for a really, really difficult TMJ case. or if you've got a case that's on that neurological side that you really, really have to fine tune and be careful what's going on with that TMJ. Okay. Neurological disorganization and switching. A couple of things that are going to be really important here. Let's say that we're just doing one of our basic tests here, and we've got the patient nice and relaxed, and I internally rotate the legs. Okay? You can actually see that this left leg internally rotates more. I would suspect that the psoas on this left-hand side is probably the weak one. All right? I could have her walking, and I could see maybe a short stride on this left side, which again tells me there's probably a psoas weak over here. But when I actually go to muscle test, the left is testing strong, and the weak one is actually the right psoas. That would be what we would call a neurological disorganization. You have neurological impulses that are supposed to be doing one thing, and they're kind of doing exactly the opposite. Okay? That's where this starts coming into play. Now, if we started off with a strong muscle, so go ahead and hold that. We've got a strong muscle. We can start going through our basic pattern. Two-hand therapy localization over K27. If we create a muscle weakening there, we're going to want to go through all of our cranial adjustments. This is why the breathing pattern can be so helpful. We'll go through our half breath in, full breath, forced full breath, blow it out half, full breath out, force it out, and we'll go through our patterns that way so that we can see what exactly is going on with our cranials. We'll want to fix. It's almost like opening a program on a computer. We want to keep her with the program open and fix the cranials while she's still holding this position for the first part. And we're going to go a little bit deeper. We pulled off the first layer of the onion, so she's got K27 and now the umbilicus. Strong muscle goes weak in this position. Very simple. We're ultimately going to want to do a cranial adjustment here, so we'll go through our breathing pattern again. If you're in a big hurry and you need to move on to some other things, you can actually, with a rotary pressure, stimulate both of those and negate, for short term, that switching pattern to be able to move on and do some other things. Okay? So we've done our uncrossed position here with K27. We could do our crossed position with K27, which is going to again be a cranial related thing. We want to make sure that the hands are not touching each other when we're doing this. So we've gone from uncrossed to crossed without touching. We've got our K27 in the umbilicus, and then we can switch K27 and umbilicus. Again, that's going to be a rotary pressure. Now we're going to do the GV27 and CV24, so we're going to have the index fingers on the upper lip and the lower lip. Essentially, our treatment is going to be to CV24 and to CV2. Okay, so we've got our CV2, if we remember, right above the pubic bone, and we're basically going to be holding that pressure. And we can actually, it's almost like you're going to be feeling pulses kind of, but you're going to have a little bit of a rotary pressure on both of those, and we'll go back and we'll retest that. Okay? Let's see, pubes. One thing that we're going to want to also do and look at when the patient is doing this, I'm going to be holding here and here with that rotary pressure, or the patient could be doing right on her own lip that little bit of a rotary pressure. I'm going to want to be right at the tip of the coccyx here, holding that pressure while I'm creating that rotation here. So it's actually a 3-point contact, so we want to make sure that we're on top of doing all three of those. Another thing that we could do, just to go even a little bit deeper, is with a switching pattern. I'll start out with a strong muscle, and I actually want to have the patient going through different cardinal gazes. We're going to keep it really simple at first, and we can have the patient's eyes going in a, from my point of view, clockwise position, and then retest, does that create any weakening, or counterclockwise. Very important here, we could actually fix the cranials while the patient is in a phase of the eye motion that created the weakening in the first place, and this is actually somewhere where the lasers can actually come in and be very helpful with the eyes in their different gazes as well. Nutrition for switching, ePoise. This is actually one of the main reasons why ePoise was designed. It was actually designed by Dr. Goodheart. It's almost a modified version of Catalin with some extra tillandsia in it, and it also has a tiny bit of iron at the same time. And very important, very helpful for right-left brain balancing. So ADD, ADHD, any of our developmental type disorders, things of that nature. People are switching things back and forth. That's like a form of a dyslexia. We can think of things like that. Our essential fatty acids, water, neuroplex, neurotrophin, anything to support that nervous system at the same time. We may even want to check out our muscles. Our brain muscle is going to be our supraspinatus, so we could check any of our 5 factors associated with that. We want to ultimately decrease all of the stressors that we can with the way that we know how. Heal the gut, looking at probiotics, absorbing nutrients maximally, decreasing refined and processed carbohydrate. Big differences when you actually decrease that and we have a more efficient fuel coming in with our brain. They actually can create some healing of our brain when we switch from more of a processed, refined type diet over to a ketogenic type diet. Very healing for the brain in that sense. And then any cross-crawl type exercises. All right, whether it's just simple patients kind of creating flexion in both of her extremities here on both sides. We want to send the patient home with doing those types of exercises, getting the right and left brain balancing the best that we can, and have that continue outside of the office of what we're doing. Emotional recall. So with emotional recall, we're going to want to have the patient essentially pick any muscle. So I'm going to just pick a pecsternal, and we can have the patient start thinking about something that's particularly stressful. You may have gotten an idea from the history. They come in walking and they kind of just look like they're miserable. They're holding their emotional points already, and you can kind of get an idea from their history that this is going to be a part of the puzzle that we need to look at. So we've got a strong muscle to start with. I could actually, without even thinking of anything, have her therapy localize over her emotional point and see if that creates a weakening. If it does, I could just as easily hold her emotional points for her until I feel the pulses at the exact same time, about 72 beats a minute. Okay? Now, another thing that we could do to add on top of that one level even deeper with the emotionals is to actually have her think of something. Let's say that she had a relative that just passed away. I could have her think, about a year ago, grandma, grandpa, a friend, somebody had passed away. They could think about that. They want to think about the events that are around, the sounds that were around, maybe there were certain smells, things of that nature. The more real that you can make it and bring it up in the body that way, the more effective the treatment will be. And as they're thinking about those things, as the doctor will hold her emotional points, and we'll be able to feel, sometimes you won't feel anything, sometimes you'll feel them racing. You want to feel them till they're more calmed down, and again, they're going at the exact same time. Usually about the same time that happens, when it's going in a synchronized fashion, the patient will sometimes have a big sigh. It's almost like they're releasing a lot of that energy. Sometimes they'll be crying a lot, and you might even be crying along with them. You want to make sure that you're kind of protecting yourself when you're doing that. Keep yourself very, very focused on what you're doing. You don't want to be taking on that energy and those emotional things for what the patient's got going on and dealing with themselves, and you have to end up dealing with that. So you're going to want to do that. And when you're done, you're going to want to, almost like you're kind of shaking off some of that energy, kind of let that go a little bit so that, again, you're not holding on to that. All right, so that's kind of our first level there. Looking for potential B vitamin deficiencies. The hypothalamics could be very, very helpful with emotional kind of issues, maybe even on the herbal side with the St. John's wort could be really helpful as well. You may also see, because of the emotions and them being the neurovascular points, also for the pec clavicular, we'll just be even a little bit more specific and use the pec major clavicular as our muscle that we're going to be testing. Also being stomach related, they may have some form of anxiety or anxiousness associated with it. They may even have some type of an ulcer that's developed, so we might want to look at nutrition for the stomach as well. Whether we go for a Zypan or multizyme, maybe we'll want to create some healing, so we've got some okra pepsin E3 potentially to kind of help with that digestive process and a little bit more healing there. Psychological reversal. Now this is going to be a patient who, in the clear, I've got a strong pec major sternal, and we could have her say a few different things. This is the patient who, let's just say, the patient was very, very overweight and said, I want to lose weight. And that creates weakening. And then she switches around and she says, well, I want to gain weight. And she actually strengthens significantly to wanting to gain weight. That's basically a psychological reversal. You're getting the opposite of an effect with those types of statements that we'll end up seeing here. And usually you're going to have a scenario where both show up. You not only weaken to the positive statement, you actually strengthen to the negative statement. Okay? So when that happens, what we're going to want to do, in this case I'll just use this muscle as a strong muscle. Let's say that she says, I want to be successful. Okay? So we'll have her say, I want to be successful, and that created weakening. So I'm going to go over small intestine 3 and small intestine 1 on both sides and see what creates the negation of that. So if she, go ahead, we'll say, I want to be successful.
I want to be successful.
That creates weakening. So we'll go ahead and I can have her there, but before we do that, I'll have her do the opposite. I want to lose lots of money. Go ahead.
I want to lose lots of money.
And now she strengthens up really hard and she's fine. She has both pieces of that. Now, I'll have her therapy localized over small intestine 3. She now says, I want to be very successful.
I want to be very successful.
And it's strong. That's the one that we're going to want to stimulate. So I actually will, while she's saying over and over again, I want to be very successful, I want to be very successful, I'll continue to tap that point, small intestine 3 for her. And that should help reverse that psychological reversal on her. So then when I go back, I want to be successful, it's strong, I want to lose lots of money, that makes her go weak. That's how it's supposed to respond for her. But you could use this under any circumstances over success, whether it's with your practices, whether it's, I want to have a wonderful family life, I want to have great relationships, things of that nature. And you could use the positive and negative statements of that exact same thing for psychological reversal using small intestine 3 and small intestine 1 again. Okay. Alright, so phobias and anxieties. Some type of a phobia, whether it's fear of snakes or fear of heights or fear of eating well, it could be any type of a phobia or anxiety that the patient has. What you're going to want to do is have the patient think about whatever it is that they're having a fear and anxiety about. The more real that you could make it, the better. If they're scared of spiders and you've got some big, huge, massive tarantula that you could have next to them, then you'll be best off, you get the strongest results that you want to for that patient. Essentially, we'll start off with a strong muscle. We'll have the patient thinking about whatever it is, making it as real as possible. If you could do this on the top of a building, as somebody that is scared of heights, then that would be ideal. Then we're going to want, so that would create a weakening. I want to go through and find, through my different alarm points around the body, what negates that particular positive challenge there with the phobias and anxieties. So very commonly we could end up going over the liver, for example. Sometimes it'll be right over the stomach alarm point. Let's say that it's the stomach alarm point in this case. It's associated with anxiety anyway. It's a very common one that we'll see. When it strengthens to that, even with, while she's standing over a ledge and she sees that height and she's all freaked out, and that still creates a strengthening now that she's holding that stomach alarm point. What we're going to do is go to our beginning and end point for that stomach meridian. So I'm going to be able to tap over the stomach beginning point, the end point on the second toe, and I'll actually continue tapping that while she's thinking about whatever the problem was, the phobia and anxiety, looking at down the big skyscraper, whatever it is, and continue tapping that. We'll have the patient basically have a subjective scale out of 10. At first, she's screaming, she can't get near the edge, she's a 10 out of 10. We go through that while she's thinking about it, and maybe she's down now to a 5 or a 3. We want to try to get that down as low as we can while the patient's doing that. Okay, that's going to be our phobia and anxiety technique. The next one that we're going to have is our temporal tap. Now, temporal tapping can be used a couple of different ways. Let's say first that I had a TFL. So I tested the TFL, it was weak, and we'll go back to acupuncture. We went 1.5 sun lateral to the umbilicus, and now it's strengthened to its own alarm point, which means I'm going to go to tonification, large intestine 11, and stimulate that. I'll adjust L4, L5, the associated point if it's present. I'll stimulate the tonification point, and I have a strong TFL. But what if we miss something? One of the other 4 factors. What do I do now because the TFL is already strong? Do I either wait until a week or 2 later when the patient comes back and now it's weak again? Or I could use the TS line, the temporal tapping. I could basically, in a direction that's going back along the TS line, normally how you would test it, I could just go ahead and tap over the TS line and then retest the TFL, and while the patient is therapy localizing to one of the other issues. So let's just say that we're like the lymphatic here, I could have one of the other 5 factors while I'm tapping over that, and now she'll actually weaken, and I know that I've got to treat other factors associated with that. I can also use it to see if nutrition is going to be involved with the patient. So I can have her 2-hand therapy localized. Let's just say that I have her over the lymphatic. I could have her therapy localized with her other hand, in this case, in the posterior parietal eminence. I'll have her hold that. And I'm going to go ahead and have her push. And if that creates a weakening, now I could start adding some nutrition in and see if that creates a strengthening, a little bit more specific and needing some nutrition for the large intestine here. Or, in this case, when we're talking a little bit more about the emotions right now, we're going to use them for habit control. Say it's somebody that needs to quit smoking, they need to quit on the amount of junk food that they're eating, whatever habit it is that they need to change. So let's just say that it's cigarettes, for example. So what we'll do is we can have the patient repeating that while I've got a strong muscle, okay, on the right hand side it's just going to be a difference with the wording. On the patient's right hand side, they're going to basically be using the negative form of that. So I have no need. I have no need for smoking. I have no need for smoking. What the patient could do this themselves, right hand on the right hand side of her body, or the doctor will be doing the left while looking at the patient. I have no need for smoking. I have no need for smoking. I have no need for smoking. The opposite side, the patient's left side, is the positive statement. I can get along fine without smoking. I can get along fine without smoking. Or let's say it's sugar, with those big sugar cravings. I have no need for sugar. I have no need for sugar. I can get along fine without sugar. I can get along fine without sugar. Something that basically, habits change typically when you do something consistently for about 21 days. So the more that you can have the patient doing that every single day for several weeks, will kind of get that ingrained into creating a new program psychologically for the patient. It'll become much, much easier for that patient to get over those cravings and get through what it is that they're trying to get through. Okay. The pineal. Now with the pineal, I'm just going to grab this very quickly. One thing that we're going to see with the pineal gland here is that we're going to want to start out with an endocrine muscle of some sort. We're testing endocrine related issues. And let's say that I just start off with a sartorius here just to keep it easy. Alright? Strong in the clear, but it could pretty much be any muscle. Now, what I want to do is try to block out all light. Okay, so I can take a blanket, I can take something and just cover up the patient's entire face, make sure that they can still breathe. Okay? But we want to block out all of the light, not just the eyes, and then retest that muscle. Retesting that muscle now creates a weakening. So what we're going to want to do is look at nutrition for the pineal. So we might want to look at something like neuroplex, for example. And then what we're going to want to do is this turns into a cranial-based adjusting, where we're going to want to go in and separate the lower jaw, and then we're going to actually end up separating, taking our fifth digits on both sides. We'll stick our fingers way back till we get to the pterygoid processes, and we're actually creating a separating there as well. So the lower jaw and with the pterygoid processes, opening that up, will create a little bit of a pumping mechanism for that pineal, kind of wake it up a little bit. We want to look at our amino acids, the tryptophan that we're getting in. Maybe there may be a need for some melatonin. Likely, if we have enough tryptophan, we get that working with the pineal, the body will make its own naturally the way that it was supposed to and kind of reset that. It can be very helpful for patients that end up having issues when the clock is changing, you know, an hour ahead, an hour back, or they've been on some flights that cross several time zones. It could really throw off their internal clock, and this could really help with the patient that's going to be able to sleep a little bit easier and when they're supposed to be. Okay. So most of the rest of the things in session 7 I've actually pre-recorded. There's a lot more lecture based in that as well, all with the endocrine system. So we refer to some of the other seminars where we get into a lot more of the nutritional side with that endocrine system. That'll actually give you a review there that you'll want to have, on top of a review of all of the nutrition in a lot more depth. So more or less moving on to a lot of the things in the GI side of things, a lot with the more systemic based things that we cover in session 8. When we're talking about GI disorders, we want to make sure that we're getting a balance of that sympathetic and parasympathetic nervous system. Now think again of all of the stress, fight or flight type things that are going on, and we get that sympathetic dominance. The first thing that's going to stop working is our parasympathetic based organs, our visceral things. All of that energy that was going to help us rest and recuperate and to digest is going to be diverted to running away from a tiger or whatever it is that we're dealing with as far as our stress is concerned. So we want to look at our adrenal glands and helping to calm down whatever stress that we can on the body. And we'll be looking at a couple of different things as far as that's concerned. A review of our pH, our salivary pH, we want to be about 7.4. So with that, we more or less aren't going to get dental caries. As we get that pH that's coming down to a 6.4, which would be 10 times more acidic, or a 5.4, which is 100 times more acidic, first thing that we want to start thinking about is our essential fatty acids to try to bring that oral salivary pH back up for the patient. Just make sure they haven't eaten or drinking anything within probably a good hour period of time when we're doing that testing. Okay. Now with the ileocecal valve, we can go ahead and have the patient lay face up. Sympathetics or in parasympathetic balance with the GI tract, largely going to be very parasympathetically driven. So we can do our vagus nerve decompression, that's all in your textbooks, simply by basically having your fingers right in that whole suboccipital region and letting the patient's head just relax. You'll actually feel those suboccipital muscles start to let go, and that will actually decompress a little bit, some with that vagus nerve, and also checking all of our different craniosacral mechanisms that will take pressure off of our vagus nerve and help with the digestion in a little bit more efficient manner with that as well. With the ileocecal valve, we want to largely be looking at our large intestine related muscles. So we had already talked about our TFL. Very commonly we're going to want to go ahead and do that. We'll have the patient typically right over McBurney's point, two-hand therapy localization, directly over that. Strong muscle is now weak. All right. Now we need to actually figure out what direction we need to have that ileocecal valve go. Do we need to come up, cross to the clavicle to close it? So we need to close that ileocecal valve. If that creates strengthening now, I know that I need to close that valve. So there's a very specific combination that we're going to have with this particular scenario here. What we're going to want to do for this patient is we're going to have bladder 58 on the left hand side. We'll stimulate that. We're going to come over to K7 on her right hand side. We're going to do the neural lymphatics over the ASIS and over the AC joint, the bicipital groove here. We'll stimulate those neural lymphatics. We're also going to stimulate the neural lymphatic over C3 on that right hand side. We'll check for adjusting C1, and we'll be checking for C5. And let's come across here. So when we've got C5, that's going to be an issue here. We're going to really want to go ahead and look at the opposite, the Lovett brother here. So when we go ahead and we're going to adjust our C5, if needed to be there, we'll end up at L1. We'll adjust all of those things, stimulate what we need to. A couple of things that will also happen when we've got an issue with the bowels and an ileocecal valve, sometimes we'll end up with bags under the eyes. And when we've got that, we'll want to make sure that we're checking our zygomatic sutures. So we've got 3 of our zygomatic sutures that we're going to want to adjust. Again, remember from adjusting those, our cranials is where we challenge together, we challenge to separate, find the phases of respiration that negates that, and fix accordingly. That'll help open up, allow some drainage to take place there. We've stimulated our lymphatics. We've done what we needed to with our acupuncture points. Now to fix it, we'll come around to the opposite side of the patient, right over McBurney's point, and I'm actually going to be pulling again across to the clavicle in a very gentle wave-like pattern to help close that valve. It's a mechanical based valve, so if we get that pressure up in this direction, we'll actually start closing it. Versus the opposite direction, coming down towards the iliac crest, towards her hip, we'll actually be creating pressure as though we had pressure coming from the small intestine. We'll actually open the valve, okay? When we're looking at nutrition for the GI tract, one of the very common ones we'll see is using the chlorophyll complex from Standard Process. But anything GI related, okra, pepsin E3, we've got the multizyme, we've got Zypan, Spanish black radish, but especially with that chlorophyll to help with detoxifying the gut and actually getting a lot of nutrition at the same time. You want to stay away from a lot of roughage, a lot of spicy foods, while that's trying to heal. For about 2 weeks, we want to stay away from alcohol and things of that nature with the patient. Now, if that particular valve was in a closed position and we need to open it, we'll actually, the scenario we would see is TFL is weak. We have the patient therapy local, or a strong muscle, therapy localized causes the weakness. Now we hold inferiorly and lateral, and that actually strengthens it again. I know that I need to open that valve. So a little bit different with my points and what I'm trying to stimulate here. I'm going to actually be doing bladder 58 on both sides. Okay? I'm going to be stimulating my 8 through 11 ribs bilaterally for my lymphatics. I'm going to challenge and adjust C3 and L3. Okay? And then very similar with my nutrition to help with the GI tract there, staying away from a lot of really heavy roughage for that period of time. Now the opposite side is going to be our valve of Houston. Everything that applied with the ileocecal valve that I just mentioned applies to the valve of Houston, but in reverse. So when the ileocecal valve was open and I needed to close it, and I went to the opposite, bladder 58, and same side, kidney 7, if it was the ileocecal valve that I had to close, I would be going to the opposite, bladder 58, and the same side, kidney 7. So everything that applied for the ileocecal valve applies to the valve of Houston as well. Okay? Things that you really want to think about this is very, very important. If you end up having an ileocecal valve, an open ileocecal valve problem, you could have a lot of waste product bringing in and holding onto a lot of water that could really increase a low back pain. It could significantly make it worse for a PMS type situation. But toxicity anywhere in the body could actually present itself in almost an infinite number of ways. So you almost always want to check this on every patient. You may even want to do that on every single visit. Just as a quick scanning, have them therapy localized. You may have a scenario where you've got a weak muscle and it just seems like you've gone through origin insertion, all of our trauma type techniques, you've gone through all 5 factors and you just can't seem to get that strengthened. You may want to go ahead and therapy localize over the emotional points, have the patient therapy localize over that ileocecal valve, and see if something may be going on there that really strengthens that up, because it could be a toxicity issue for that particular patient with that going on. A visceral manipulation now. A very common one that we're going to see is going to be with a bladder. Now you may have a patient who just had a child, a vaginal delivery, all of the organs, everything's been pressed inferiorly, and there could be some issues with that. We want to make sure that the organs that we're working on and the abdominal viscera, we're actually testing the correlated muscle. So in this case, say that we're working with the bladder. We'd want to go ahead and check that tibialis anterior. So let's say that we have a weak tibialis anterior. The patient could create some pressure over that bladder in a superior direction to kind of hold that back up. And now my tibialis anterior is strong as a rock. That's what I want to see. So to fix that particular scenario, I want to have the patient's legs in a bent, comfortable position, almost always when the patient's in and you're working on the abdominal area. As the patient's breathing out, the patient's going to be lifting the arms up over the head. As the patient's also breathing out, I'm going to have inferior to superior direction over that bladder. So I'll have the patient take a nice big deep breath in, blow it all the way out, and my pressure is going up superiorly, helping lifting that bladder. She'll bring her arms back down. I'll move a little bit more inferiorly. Each time we'll do this 3 times. Breath in, have her breathe it all the way out, and I'm bringing that pressure superiorly again. And we'll do that 3 times. We can do that with any of our visceral-related organs. More commonly, with that bladder is going to be something that comes up a lot. The small intestines, the stomach sometimes will be an issue, and maybe even with the uterus. We'll use the piriformis muscle with the uterus. Okay. Diaphragm imbalances and issues. Now we might have a situation where we've got a pec major clavicular that may even be strong in the clear. If there's a major problem, sometimes that'll even be weak when we've got a problem going on with the diaphragm. So let's say that we've got a strong pec major clavicular. I could have the patient therapy localized right just inferiorly to that xiphoid process. And we're actually a little bit of pressure inferior to superior, almost like we're kind of jamming that together. Or more like we're inducing more of a problem with a gastric reflux, a GERD type of an issue. So I create that pressure, and now strong muscle is going to be going weak. Okay? A couple of things could take place there when I've got a regurgitation type issue coupled with a diaphragm issue. First thing I want to look at is everything that attaches to that diaphragm. Why is it being pulled anyway? And we remember from our anatomy, we've got our psoas that's going to attach on that lesser trochanter, come all the way up through the pelvis, every low back vertebrae and disc, directly into the crura of the diaphragm. Okay? So I want to make sure that psoas on both sides is functioning the way that it's supposed to. Also, not only when I have a strong psoas, I want to go ahead and actually stretch my psoas a little bit, make sure that I don't have any fascial shortening. If that creates weakness, I want to do whatever lengthen, whether I'm using the percussor, ART, Graston, anything to lengthen that psoas muscle. I want to check for a thoracolumbar fixation or adjustment, because all of that comes together, the crura, the diaphragm, the psoas, all in and around that thoracolumbar region. And I want to make sure that's adjusted and free as easily as possible. Okay. Other piece of that as well is that I want to have the patient taking a breath in, blowing it all the way out, and on the breath out I can actually inferiorly traction if there happens to be something like a hiatal hernia or a problem going on with that as well. So we've got all of those pieces coming in together dealing with that. Now we can check for a few things along the way. We always want to measure. So if you have an inspirometer, you can measure how somebody's vital capacity is going to be. We could measure somebody's breath holding capacity. We should have no problem holding your breath for 40 seconds. It should be very easy. If you can't do that, maybe something like a cataplex B, sucking on that, maybe they'll go from 10 seconds on up to 20 or 30 seconds just while sucking on that. That could be a big difference. We want to look at the rib excursion. So as the patient go ahead, take a nice breath in, I should see my fingers being able to separate and coming back together. If I don't have rib excursion, I'm going to need to adjust my ribs. Maybe there's a lot of fascial adhesion, so that I really need to get that motion as much as possible. I can even be kind of jiggling the rib cage back and forth. It should cause her whole torso, like it is now, to be kind of jiggling back and forth like that. Sometimes you push on one side, it'll jiggle. The other one almost feels like you're going against a brick wall. That's going to decrease vital capacity. It's going to affect the way that the diaphragm is able to when you're breathing, be able to drop, and while you're blowing out, come back up again. Again, we want to look at the nerve supply as well. Everybody's easiest mnemonic that they learn in school is C3, C4, C5 keeps the diaphragm alive. Absolutely. We'll look at C3, 4, and 5. We'll look at the Lovett brothers and adjust that as we need to as well, and especially looking at that thoracolumbar region. We want to test that. Also look at the neurovasculars and lymphatics of the diaphragm. So neurovascular, we're going to basically be over the entire surface of the sternum. Okay. Neurovascular points, we're going to be a couple. We've got over lambda in the back. About an inch superior to that is going to be another one of our diaphragm points, and then over bregma. So we've got all three of those points being our neurovascular points for that. If we need to increase our respiratory motion of our entire axial skeleton, all of the different pieces that come into play. As we breathe in, the pelvis actually will spread a little bit, ASIS will come a little bit inferiorly. And I'll do each of these with 10 respirations on a big deep respiration in. So as the patient breathes in, nice and deep, I'm separating the ASIS in a separation in inferior direction. After 10 of those, I'll give her a break so she doesn't hyperventilate. And then I'll move my way up to the rib cage. She'll take a nice big deep breath in. I'll help lifting the thoracic cage. We'll do 10 of those. I'll come up over the clavicles and the upper ribs. She'll take a nice big deep breath in again. And let that relax. We'll do 10 of those. I'll have gloves on. I'll grab the lower part of her jaw, separating the lower part. And then another 10, I'll be in the upper part of the jaw, right in the pterygoid process, and creating some separating there as well. Really opening up that axial skeleton as much as possible. As much oxygen, and that's going to be for fibromyalgia patients that need more oxygenation, because they need to be more aerobic instead of building up so much of that lactic acid from an anaerobic process because they're not breathing as well. To people that are just generally fatigued, they don't have energy, they're not sleeping well, they're just not feeling well in general. We want to get more oxygen. Okay, it's going to be very important for us to work on these particular points to do that. Of all of the techniques, Dr. Goodheart was asked if he could only do one thing in practice, what would it be? And he actually had said retrograde lymphatic. Lymphatics are basically the sewer system of the body, and if you're stagnant with your sewer system, you're just a toxic mess everywhere. So we want to take a look at that. What we'll end up doing is we could take a bilateral pec clavicular, and it seems strong in the clear. That's good. What we'll do is create a retrograde position, and you can hold the patient's legs. If you have a table that'll tip, that'll be fine. You'll hold that for a good 30 to 60 seconds, and then we're going to go back up and we're going to test the pecs. Let's say that that made it go completely weak. That's the indication for this retrograde lymphatic technique. What I'm going to want to do essentially is go through and either percuss, ART, grasp, and I really want to get through my chest musculature, my pec minor especially, help open all of that up. We're going to go ahead and we're going to test all of those things. We'll look for that weakening. We're going to stimulate the lymphatics, the junction of the xiphoid and the manubrium. Okay, so we're going to stimulate that particular area. We can look for a low dose of A or some iron, anything that's going to help with lymphatic drainage. We may even use something like multizyme in between meals to help with digestive purposes, breaking things down a little bit further. The intracellular matrix, a lot of water to help with that drainage. We want to help the patient on a regular basis be stretching and opening all of that up. So once we open all of that up, we kind of help with drainage of that lymphatics. We'll go back and we'll retest. We'll have the patient in this position, and we could retest any muscle. The TFL, we could use our pecs like we were doing. It's nice and strong. We've helped clear that. And this is another instance where our main lymphatic duct, our thoracic duct, is on this left-hand side. Okay, you get all of that buildup of toxic mess. We could be considering issues that take place where we've got a buildup in our sinuses because it's not draining properly. Maybe we even end up developing some type of a lump through this particular area on both sides. We've got our thoracic duct and our right lymphatic duct. So we could have issues there. Our sinuses aren't draining, so you end up with that kind of rawness in the back of your throat because it's draining back there, or everything's just staying in the sinuses and becoming painful for a patient that way. Not necessarily a problem where you need an antibiotic, it's a mechanical drainage issue. So we want to drain all of everything, whether we're percussing, we're doing our cranials, maybe we're turning down some of our spindle cells over our temporalis, our procerus muscle. We're going to maybe even percuss over the sinuses themselves, opening up our lymphatics here. Our lymphatics for our large intestine, really helping that, will really calm down and help a lot with both GI related issues and with our sinuses to be able to flow the way that we need to. We've covered gastric regurgitation. Now with ionization takes place. Read the specifics in your notes. Essentially what we need to know, left nostril is more of a negative ion that will be created, and on the right hand side it positively charges. So why don't you go ahead and sit up for me. So what we'll do with the patient is I'll start out with a strong muscle, use the supraspinatus. I'll have her block off one of her nostrils and have her take a big deep breath in just through the right nostril. If that causes weakening, okay, you can let that relax, through the right nostril, that's the side that is more of the negative, the positive ions. So the right nostril is going to automatically tell me how I'm going to end up tapping for the patient. I'll be tapping on the right backhand side of the patient over the thoracic cage, and I'll be on the left thoracic cage on the front when I'm doing the tapping portion. But now I need to see which brain side is going to be the stronger of the two brain sides, if you will. So we'll start off with a strong muscle. I'll have the patient start humming a tune. Okay, so we start humming, more, you kind of don't want to do a humming tune that there's a lot of words to and you're actually singing the words in your head. Just picking something and kind of humming so that you could just kind of turn on the right side of the brain. It's a little bit more abstract, that more musical section. So we're humming something, that creates weakening, let's say. So we're not going to want to use the right brain response with humming. Let's go over to the left side. We start counting by 3. 3, 6, 9, 12, and that's very strong. So we're going to want to do the left brain strengthening activity while I'm tapping. So I'll have her count by 3s. While I'm tapping, 3, 6, 9, 12, 15, 18. And we're going to do that for probably 30 to 60 seconds, and then we'll go back and check. We'll have her plug the left nostril, and I will have her breathing in through the right hand nostril again. That's strong, and we fixed what we wanted to. That's our ionization technique. Same thing holds true. If she had held the right hand nostril, breathing in through the left side, would mean the left backhand side is where I tap, the right front hand side of the thoracic cage is where I tap, and again I find the brain activity that creates strengthening. You want a strong, smart brain that's working well. So you pick the brain activity that's strong while I'm tapping in that particular direction. Pre and post cordial tap. Now this is a great technique that we actually can look at well with any of the breathing type patterns that we were just showing. We want to increase oxygenation. We've got 60,000 miles of capillaries to pump blood through. It doesn't make sense that a heart is going to pump a little bit and all of a sudden that's so much power that it's going to pump something 60,000 miles. It's not going to happen. What happens though is that an electrical impulse will take place during that pump, and it's going to charge our blood cells. And that charge, like charges repel each other, it's going to push our blood cells electrically through our entire cardiovascular system. We're going to help with some of that charge essentially with what we're doing. And we can check with a blood pressure cuff on the calf. All right? If we've got between 140 and 180 on the blood pressure calf, we'll be thinking possibly a vitamin E or a calcium. If we've got one leg that's less than 180 and one leg that's over 180, maybe we've got a category 1. But if you've got both legs that are very significantly on that low side, maybe you've got somebody with a lot of diabetic ulcers, maybe you've got some kind of claudication issues, they're blue in their legs, they're always cold, they're having issues in that way, and we need to increase oxygenation, increase blood flow, then we definitely want to look at the pre and post cordial tap. That'll be something very helpful there. Okay. So for this particular one, we're going to start off with the brain functions again. So let's just go back to the original one. We'll say that humming did not strengthen, we started with a strong muscle. It's not strong anymore. That actually weakened it. We don't want to do that. Counting does create strengthening and it stayed strong. That's good. We know left brain is what we want to do. So what we're going to do in this case, counting causes the strengthening, right brain causes the inhibition. So if the right side causes the inhibition, we're going to be tapping on the right side while the patient is always doing the positive strengthening side of her brain. So she would be counting again 3, 6, 9, 12 while I'm tapping on the weak side of the brain with the humming. Okay? Opposite true on this side. We'll just say that she counted 3, 6, 9, 12, created weakening. I'm tapping on her left side while she's doing the humming. Alright? Then we'll retest our blood pressure cuff. A lot of times that'll go up to 200, 220, 240, and we're going to be increasing that electrical impulse in the heart for that patient in that way, which will be great there.